Way to Paces, the right way.
Right, welcome to Way to Paces, one of the free sessions. And today it's about Station 5, brief clinical consultation. And Dr. Kinley is there to be a candidate, and then he's going to try the role play scenario. In terms of time, in exam, you will have 2 BCCs. You'll be given 5 minutes before the BCC station. And here we're going to do 1. So I'm going to give Dr. Kinley 2.5 minutes. And then with the BCC station, 6 minutes, I'll give a warning for 2 more minutes. That constitutes 8 minutes. And then 2 minutes with the examiner. And it's total 10 minutes. Okay? Right. After the role play, we will discuss about how to approach like a step-by-step, depending upon how the role play goes. Now your time starts now, Dr. Kinley. Okay. I've done the scenario in the chat. Okay. You are a doctor in a respiratory outpatient clinic. 72-year-old David Jones with a diagnosis of COPD has been referred with progressive shortness of breath and frequent respiratory tract infections. Please take a focus history, do focus examination, and answer his concerns. So people who are listening, I would suggest to kindly make a note of things, what you would ask and what you would like to examine. That's where you can check whether you're doing the right thing or is there any need to change slightly your approach. Ready?
Yep.
Okay, can start now.
Okay. Hello, good afternoon. I'm Kinley, one of the doctors in the clinic today.
Yeah.
Are you Mr. David Jones, 70 years of age?
Yeah.
Hi, Mr. David. I'm here today to have a chat about your medical condition. After that, I'll examine you. Is that okay?
Yeah.
So I gathered to note that you have been bothered by progressive shortness of breath. Can you tell me more about it?
Yeah, because see, I have COPD, so I know I will be short of breath at times, but it's getting worse nowadays. Let's say in the last 6 months, and I've been admitted to hospital for chest infections as well, once or twice. So it's getting worse and worse. So that's why we thought we can have a word with you as an expert and see what your opinion is, and that's what the GP is thinking the same.
Okay, I'm very sorry to hear about that. I'll try to get to the bottom of this and see what I can do to help you.
Uh-huh.
Do you mind telling me for COPD, for how long have you been having this COPD for?
10 years.
10 years. And are you on any regular medication?
I'm on like a salbutamol and ipratropium.
Okay, so have you been using this regularly?
Yeah.
Okay, and do you mind telling me, did you notice other symptoms like cough and producing phlegm?
Yeah, I do get cough and phlegm. Sometimes it's white, sometimes it's like a mucky yellow green.
Okay.
So when it's mucky yellow green, I'll be given antibiotics. Other times, no.
Okay, and any fever associated with the symptoms?
No.
Okay. Do you have any weight loss at the moment?
Yeah, that's worrying as well. It's
Okay.
I lost about 3 kilograms in 3 months.
Okay, was it intentional or unintentional?
No, not at all.
How about your appetite?
Appetite is good.
Okay. Any lumps or bumps anywhere in your body?
No.
Okay. So do you notice any chest pain?
No.
Okay. Okay. Then any problem with your bowel work and water works?
No.
Okay. Any skin rashes or joint pain?
No.
Okay. Apart from COPD, do you have any other medical conditions in the past?
I have a diabetes.
Okay.
I take a glycoside 80 milligrams twice daily.
Okay. And what was your last 3 monthly blood sugar check?
I can't tell you the value, but it's everything under control.
Okay. And have you had any surgeries in the past?
No.
Okay. Can you show me your medication list, please?
Yeah, it's only glycoside, nothing else.
Okay. Are you allergic to any medication or anything
No.
that you are aware of? Okay. So do you have any pets at home?
No pets, no.
Okay. Right. And did you travel anywhere in the past? Recently, maybe?
No.
Okay. Do you smoke?
Yes.
Okay. Do you mind telling me how many cigarettes over how long?
20 cigarettes per day for nearly like a 20 years.
Okay. I think you do acknowledge that this is quite a lot. And, smoking do have adverse effects, especially in the lungs, and you are having a lung condition. So have you ever thought of quitting it?
Not really.
I highly recommend that you try quitting it because it must be affecting your lungs already. If you are interested, then I can refer you to the smoking cessation clinic.
Okay, we can think about it, but not at this minute, please.
Okay. Okay, fine. How about alcohol?
I don't drink.
Okay. What do you do for a living? Who do you live with?
So I'm 72 now. So I was a builder, but
Okay.
now I can't do like a full work because of my breathing. So now I'm
Okay.
not doing much of the work, and I live with my wife.
Okay. Okay. And have you ever worked in the factories or industries before?
No.
Okay. Okay. So, okay. Do you mind if I examine you now?
Yeah.
Okay. Okay. First of all, can you show me your hands? I'm particularly looking at whether there's any clubbing.
No clubbing.
Okay. And is there any peripheral cyanosis or
No.
any
No.
star staining of the fingers?
Plenty.
Yeah. Okay. And can you turn your hands over? And I'm specifically looking for any thinner or thinner wasting of the muscles.
Yeah, you can find some wasting.
Okay. Then I'm going to check the pulse.
Vital signs normal.
Okay. Then I'll just have a look at your eyes, please. Looking for anemia.
No pale.
Okay. Then can you open your mouth? I'm just saying whether there's any central cyanosis.
No.
Okay. Then can you please look over to your left shoulder? I'm going to check the JVP, whether it's elevated or not.
JVP normal.
Okay. So do you mind, please? I'll just check the glands of your neck, if that's okay. I'll just go
2 minutes more.
behind him, and I'll just palpate whether there's any lymphadenopathy.
No.
Okay. Then I will briefly examine from behind.
Sorry,
and
examine
ask him-
from? What is that?
behind
Examine.
his back, at the back.
Okay.
Yeah, I'm just auscultating whether see any wheeze or crackles or any focal signs of focal consolidation.
Bibasal crackles are there.
Okay, right, and I'll just palpate the ankles with this to see if there's any peripheral edema.
Mild filial edema there.
So, Mr. David, do you have any concerns at this moment?
Oh, I don't know what's happening because my weight is going down. I'm getting more breathless and I need to having lots of infections. So I don't know what's going on. Is the COPD getting worse or is something else going on? I'm not sure.
Well, after having chat and examining you, there are so many reasons why a patient with COPD will deteriorate. But particularly, I'm concerned here that you are a heavy smoker and you have weight loss. So I think at this time, it is very important that we investigate you further. And for to investigate you, we'll be doing blood tests, X-ray of your chest, and we will also be examining your sputum as well. And after we have that report, then I think we can have another meeting, and then we'll proceed from there.
Okay. I had plenty of chest X-rays. Do I still need to do it?
When was the last time you did it?
1 month.
Okay. If so, I'll have a look at your X-ray again.
Yeah.
X-ray and I'll see whether you need one again or not.
Okay. Do I need to get admitted to the hospital?
Because after examining, I found your vital signs are normal.
Time is up.
Okay.
With the examiner. What are the differentials here?
The first differential is the infective exacerbation of COPD. The second is lung cancer. And third one, I thought it could be bronchiectasis.
Why do you say bronchiectasis?
Because he has had recurrent respiratory tract infection, and it is possible theoretically that he might have a residual lung damage, and that could be causing, or this could be TB as well. I need to explore the TB also, chronic infection like TB.
How do you treat COPD?
COPD management is divided into general, acute, and chronic. General is patient education and counseling, nutritional optimization, and medical treatment. We have in acute setup, we have steroids and in a form of injection
How do you
oral.
treat this particular patient?
This, I think he will need a course of steroid again, short course of steroid, antibiotics, and a nebulized therapy.
Okay. What nebulizers?
Nebulization, we have short-acting beta-2 agonist, short-acting muscarinic agonist, long-acting beta agonist, and long-acting muscarinic agonist.
We give both short-acting, long-acting.
Long-acting muscarinic antagonist.
You said short-acting and long-acting. Do you give both?
No. I'm saying this as for chronic management. We have a stepwise management according to British Thoracic.
Okay. Time is up. Everything is done. Okay. Now, off the roll, the candidate, examiner, everything. How is it?
In this short span of time with the pressure and all, I think we are getting mixed up with the differential diagnosis, which to put first and which to put second. And then spontaneously, it's very difficult to come out with the management when examiner asks suddenly, how will you manage? Then I think it is challenging within this short period of time.
It is. But again, see, in practice, as a preparation for PACES in station 5, we usually do all the like uncommon or a little bit away from normal clinical scenarios. But people keep exacerbation of COPD, exacerbation of asthma, and then heart failure exacerbation. So definitely you might not have symptoms. You might not have a signs, but people will have all those scenarios. So that is why you need to be, this is the bread and butter every day, isn't it? So every day you see, you examine, you come to a conclusion, you manage, and that's fine. And you told about like putting things in this particular patient, and that's where we need to develop that skill. See, generally everybody can tell. The first step is this one, and then like a SAMA, SABA, and then LAMA, LABA, and ICS, inhaled corticosteroids. Again, like a short acting. When I say SAMA, short acting, long acting, bronchodilators, inhalers, and then that people can tell. So it's like a fixing where he is. That's important. So in that case, yes, I think you got a little bit confused with the short acting and long acting. That's why I wanted to tell you. So this patient has a short acting and long acting already. You're right. You will need antibiotic. Steroid, yes, he will need a steroid, an inhaled steroid. And then we need to, if it's not responding or anything, the next step would be like a long acting. Name long acting inhalers.
Long acting
agonist, beta agonist.
Long acting beta 2 agonist.
Yeah.
We have salbutamol, terbutaline.
Okay, then.
And long acting muscarinic, we have tiotropium.
Tiotropium and solmetrol as well. Solmetrol. Okay. And are you aware of any drug or which is a new medicine can be used to treat the flares?
In COPD?
Mm-hmm.
No, not a.
Roflumilast.
Okay.
Roflumilast. ROFLUMILAST. So have a read about the indications and things over there. So it's a new drug.
Okay.
When do you refer patients to specialist? You are in a respiratory clinic. So when do other people refer with the COPD?
Okay. So when I think it's when the inhaled long-acting inhalers and the combined steroid is not controlling the symptoms.
Mm-hmm. Okay, yeah, that's right. And we got a chat in terms of to write the drug name. So I'm just typing Roflumilast. Okay, right. See, in terms of how to go here, the procedure and step by step, I think overall you did very well because you planned in such a way, as you said, it's a time pressure. There'll be like a lot of pressure in terms of every second counts in station 5, unlike the other. You don't know how it will go, just it will go all of a sudden. Yeah. So you did ask about first of all, COPD. That's where people tend to miss it. So they would assume in terms of COPD. So you need to ask in terms of how long ago been diagnosed. If they're not clear, even then you can ask about like a FEV1. Have they done any tests and diagnosis? You can just add one more. And again, you immediately ask about the medications. That's well and good. You asked twice the medication list, but anyway, you can confirm. Symptom-wise, shortness of breath, cough, phlegm, and then fever. Very good. You ask about weight loss, good appetite, lumps and bumps. I will a little bit tricky in this case because you're slowly moving towards like a general history taking. Okay. So I can see that the bowels, waterworks, may not be relevant here. So the clear cut is just chest pain and skin rash, joint pain and all. I don't think that's absolutely essential here. Okay. So we're slowly moving towards history. I was about to give a clue and then you come back. Because when you asked about the smoking and other things and allergy medications, so you have come back perfect. In terms of cardiac history, you ask about chest pain. So it's always better to ask about the syncope as well. Syncope.
Okay.
If it's something due to the cardiac palpitation, syncope, if there is anything cardiac, just few more to add.
Okay.
Differential diagnosis. See, the questions are based on differentials. Yes, acute exacerbation of COPD, but what else could be? You're right. Could be bronchiectasis, could be lung cancer, could be cardiac cause, could be interstitial lung disease, and then could be asthma as well, bronchial asthma. So you need to ask that question as well. Any variations in the diurnal variations you could ask, because if whenever the asthma is associated with COPD, that particular group of patients will have a better response to inhaled steroids rather than the other group. So we need to ask in terms of those things. And you did ask about allergies and medication, surgery, pet, travel. Why did you ask about travel?
For TB, basically.
Yeah, that's fine. Very good. And then smoking history. Yes, you immediately said quit smoking. And then smoking cessation clinic. You ask about alcohol, occupation. And rightly, have you worked in any industry? I said no. If I said yes, that would have been another discussion. But in this case, I know it's not history taking, but it has to be crisp. So I said no. And again, whom do you live with? So I would say history taking wise, it's pretty clear, other than just adding 2 or 3 more for cardiac reasons and then asthma. Everything is pretty clear. And then if you forget about the lumps and bumps and skin rash and bowels and whatever, so you can add those in that. That's
Okay.
good. History taking part is very good. Examination, yes, again, people who are seeing station 5 from me through way to basis, it's tricky always, because I'm not going to give you the signs immediately, whether it's there or not there, because it takes time. And I would suggest when you practice between yourself as well, don't go like, for example, clubbing now, auscultation of lungs, oh no, bivalve crackles, JVP normal, no. Because the JVP, it takes time. You need to put the patient on 45-degree angle, and then you need to get the lighting properly and then inspect and looking for the waves. So you allow certain times, at least like, I don't know, which you know how it goes, about 20 seconds, 30 seconds, and then reply. So I did that, and you did that correctly in terms of clubbing, cyanosis, peripheral, central, and tar staining, and then wasting of the muscles in the hands, particularly pallor. And I said, usually vital signs will be given. So no need to worry about pulse. You can examine, but the vitals will be given. And that's why I said immediately, pulse, respiratory, okay. You could ask for oxygen saturation. That's an important thing to be added. So it depends on if the saturation is low, what oxygen you're going to give, what level you're going to monitor. So that would be there, particularly in respiratory disease, ask for oxygen saturation. So vital signs, we know everyone knows, like a temperature, or pulse, blood pressure, and things, and respiratory rate. Also add oxygen saturation in this time, because particularly in respiratory diseases. So general examination, everything is fine. And then you ask about lymphadenopathy as well, that is fine in terms of say lung. If you're suspecting mild pedal edema, you look for, that is absolutely fine. And you ask about auscultation of lungs. And I said basal crackles. Why does he have basal crackles?
In this case, I think because of the infective exacerbation.
Can you have bibasal infective exacerbation?
It's possible in COPD.
Possible, yeah. And that's why, say, I want all of you to know that bibasal crackles, we all know one is a heart failure, and that's what we need to think of, like JVP and then pedal edema and then any fluid overload. But it's common in people with COPD as well, need not be related to anything else. And it's more common in people who are bedbound, because again, it's a stasis-related bibasal crackles. It's not like whenever you see, let's say, bedbound patients with a COPD or anything else, bibasal crackles, don't think all of a sudden heart failure. So people can have lung stasis of the fluids due to their positional, and also generally COPD people can have bibasal crackles. And that's why it's important to see the previous examination and see how things go. Let's say a patient in the ward, yesterday you examined the patient, you didn't find any crackles. If I go today, I get bibasal crackles or anything, then that's a big change. And that's why when you are in the ward, and it's not particularly with the exams, practically, so do the examination and put the examination findings in the note so that the next person will know if there is any acute change. Concern, I asked about whether it's COPD or anything else going on, and you rightly said we have to investigate further with the blood test and phlegm with the sputum. You can say phlegm instead of sputum. And then chest x-ray, rightly said. And I asked about hospital admission and the bell rang. So do you admit the patient or not?
I think if this is the mild exacerbation, then we can treat on OPD basis. Outpatient.
How do you say it's mild, moderate, severe clinically?
Depending on the I think the vital signs, pulse, BP, saturation.
Yeah, and that's where I'm coming from. Saturation is the key here. It's absolutely necessary to say in terms of, let's say it's 84 and then you can't send him home. Let's say it's 96, 97 on here, you can send him home. But again, in clinic, if they ask, you can say in terms of, okay, we'll wait for the blood results and then come back and tell you over there. You can say there are different options. When I say admission, it's not like a hospital admission. There are like a day center or daycare units kind of thing, ambulatory centers in each and every trust. You can say that you stay over there in ambulatory unit until we get the results back. And then I'll come back and tell you, depending on the results, we'll make a decision whether you need to stay or you can go home. So that's a good answer in terms of over there. I don't know, you would have told that, but the time, right. Differentials, yes, you told infective exacerbation, say a lung, bronchiectasis, TB, all that I added is the bronchial asthma, and then any cardiac reasons. So always remember, any respiratory problem, you need to have a DD of cardiac, and any cardiac problem, we need to have a DD of respiration because of shortness of breath is common in both things. Management, see, when the examiner asks about management, I would generally say he's asking about managing in this particular patient and not worried about the whole BTS guidelines or the NICE guidelines. Okay. So you need to be thorough with the guidelines and then see, depending upon the mild COPD or moderate COPD, and the next stage is depending on what medications he's already taking. Then you can say in terms of, you said clearly, yes, he will need antibiotic, he will need inhale. And then when you say steroid, you have to say clearly whether it's an inhaled steroid or oral steroids, make it clear. Don't say only steroid, and the examiner won't ask you again. And whenever people ask in terms of, let's say, probing or prompting, that makes a little bit of like a going down in terms of examination or the marking schedule. So don't expect everything, may be very clear in terms of what is going on, and be specific. What examination? Oh, this is what the examination, this is what the drug. And when you say oral steroids, you can say the name, like prednisone, 30 milligrams, 5 days, and then we'll review the situation. Antibiotic, right? And you can add also, I'll check the trust guidelines and then appropriate antibiotic for this particular patient I would give, you can say. And you will say the chest x-ray is there. And that's another one in terms of whether if you get any pneumonia, then the score is there, 1265 score is there. That will determine whether we need to admit patients or not. And nebulizers, yes, always tell the name. And that's why I ask about the short acting, long acting. Yes, salbutamol, solmetrol, and everything is there. So have a look about considering all these things to the examiner. Be specific. Don't expect more questions and then digging in. You can ask, but you've got only limited time. So if you get more questions and be clear, I would say you will definitely pass this session if you do like this, but a little bit more rather than get into the trap of other things. Okay. I want to be like getting full mark, aim to get the full mark rather than just borderline and just on the border. No need to worry about it. Okay.
Okay.
Right. Any questions from anyone?
Yes, sir. Can I ask a question? Yes, sir. If we have a patient with a COPD like this, so do we need to examine the chest as a whole, like inspection and palpation and percussion and auscultation, or just the auscultation is enough?
No, not the definitely not the palpation and percussion. So it all depends upon things. If you have time, you can do it, but they ask only for focused examination. So let's say you are suspecting some pleural effusion or anything, then you can say in terms of pleural effusion that you can do a gentle percussion, say Stoney-Dell, and they can immediately listen. So in general, focused examination is the key. You don't need the detailed examination as you do in the examination stations.
Sir, for example, in this case, the position of trachea is also important because the patient who are having lung collapse due to cancer, they have a trachea shifted towards the site of lesion. So is it important to palpate the trachea in this patient?
Can manage, if you can see the collapse again, it's all either if you can manage within time, you can do it, but nobody will be saying you are under mark because you didn't look for trachea in this station. In history, in a clinical examination station, yes, but in station 5, there are lots of things to do. And you need to have a mini version of the clinical examination.
So in short, just auscultation or just the focused part of examination.
See, he asked about the first, he asked about the clubbing, the key things are clubbing, cyanosis, central, peripheral, JVP, leg edema, and then you can auscultate. So if you miss all those things and straightly auscultate, you won't be able to get marks.
Okay, sir. So respiratory rate is given, or we need to calculate the respiratory rate?
If it's not given, we need to calculate. Usually they will give vital signs. If it's not there, we need to say. We need to check, let's say. So usually either 10 seconds and then you can multiply by 6 times, or you can give 6 seconds and multiply by 10 times. But I don't think you will have time to calculate the full minute for respiratory rate as well as the pulse, particularly in station 5.
Okay. Can we ask an examiner to give us the vital result, or we need to calculate?
No, you just carry on. You just palpate the pulse. If the examiner knows, he will tell you. If it's in the scenario, no need to ask. If it is not in the scenario, you just do the pulse and count the respiratory rate as you do for normal people.
Okay, sir. Thank you, sir.
Okay.
Way to PACES, the right way.